Thank you. Good morning. So there's been a lot of concern over the past several years about the role and the risk of general anesthesia on the developing brain. This comes primarily from animal data, which has shown that sedatives and anesthetics in young rodents and mice can lead to nerve cell death, later abnormal behavior, and nerve cell apoptosis. In 2016, the US FDA released the following warning that repeated or lengthy use of general anesthetic or sedation drugs during surgeries or procedures in children younger than 3 or in pregnant women during their 3rd trimester may affect the development of children's brains. Many groups, including ACS, AAP, and others, have responded to this warning, and several task forces, including most notably Smart Tots, have been developed to study this topic further and develop human data-driven recommendations. The goal of our systematic review was to review current available literature to better inform us as we talk to other practitioners and families. The Outcomes Committee agreed on the following 4 questions. Does general anesthetic exposure in children pose a risk to their neurodevelopment, and is this risk dose-dependent? Is there a critical window of neurodevelopment during which anesthesia exposure should be avoided? Does exposure to specific anesthetic agents carry more risk than others, and are there certain agents that can be added to decrease neurotoxicity? And what are alternatives to general anesthesia in children, and what is the data for their safety? Using the usual databases, we searched relevant search terms, including all dates up to the end of 2017, ages 0 to 4 years old. We found 493 abstracts and then reviewed 56 articles. We put these into 4 different slots. Some articles were used for multiple questions, and then we used any follow-up articles from the articles in the original search. We then looked through, graded them on basis of levels of evidence, and made a consensus statement of recommendations in response to each study question. We found many limitations when we did our study. First, that these were predominantly retrospective and observational studies, and many different age groups were included. The endpoints varied between studies, and there were different measures of neurodevelopment, cognitive studies, et cetera, in each study. There was limited detail on type or duration of anesthetic agents given in many of the studies, and in most of the studies, there was no control on the indication or outcome of the surgery, including perioperative trauma and postoperative pain management. For question number 1, there were 26 studies, including 24 looking specifically at generalized neurodevelopment and 2 looking at anesthetic duration. The neurodevelopment tools that were utilized included the Bayley Scales of Infant and Toddler Development, Wechsler Preschool Primary Scale Intelligence, 3rd edition, Full Scale Intelligence Quotient, or IQ, and other measures including test scores, preschool language scale questionnaires or surveys. Probably the most robust trial so far has been the GAS trial, which is a multi-centered, randomized control trial comparing regional anesthesia to general anesthesia in infants undergoing inguinal hernia repair. The primary outcome was recently reported in 2019, and that looked at IQ score at age 5. However, the secondary outcome was reported in 2016, and this was an intention to treat analysis. 361 infants were randomized to receive regional anesthesia, with 358 to GA. 69 of the regional patients then required the addition of general anesthesia, and the average duration of Sevo was about 54 minutes. In the first study, looking at Bayley score at age 2, the authors found that there was no evidence that less than 1 hour of Sevo anesthesia in infancy increases the risk to neurodevelopmental delay at age 2 compared to awake regional anesthesia. This was followed up then by looking at the primary outcome at age 5, and this was reported again, as I said, recently in 2019. They found 205 of the regional patients and 242 of the general patients. And the endpoint was the full-scale IQ on the Wechsler Preschool and Primary Scale quota at age 5. Again, they found that there is no evidence that less than 1 hour of Sevo increases the risk to neurodevelopment at age 5. Another study that's been talked a lot about is the PANDA study, which is a prospective study of siblings between 2009 and 2015. There were 105 sibling pairs, one exposed, before the age of 36 months. Inhaled general exposure was about 80 minutes, an average between 20 and 240 minutes. And then they did IQ testing at age 8 to 15 years old. The conclusion of this study was that there is no statistically significant differences in either mean IQ scores or domain-specific neurocognitive functions between exposed or unexposed siblings. There were 2 studies looking at a cohort of neonates who were operated on before 90 days old. They were enrolled at the time of surgery, and for the first study assessed at age 1, and the second study is assessed at age 3. The surgical outcomes at 1 year, the surgical infants scored lower on 4 of the 5 scales of the Bayley score, but these were only mild or moderate delays, and they were still in the average range. 2 years later, the surgical group still had lower scores on cognition, receptive language, and fine motor skills. However, there was no difference between the surgical and non-surgical patients, or babies, in physical activity. 3 other studies looked specifically at infant exposure to general anesthesia. 2 found lower verbal scores and a lower overall neurocognitive test at age 24 months or 5 years, while 1 found no difference between groups at an average age of 12 months. There were 2 sort of interesting studies looking at siblings or twins. The DiMaggio study in 2011 looked at a matched birth cohort of an exposed and unexposed sibling. There was no data on type or duration of general anesthesia. And the risk in the exposed group was 1.6 of behavioral problems or developmental delay. However, in matched sibling pairs, this was only 0.9. The twin study by Bartels et al. Looked at twins, 1 exposed, 1 unexposed, and found that the exposed group had a lower overall educational score and more cognitive impairment than the unexposed group. However, when you looked at twins, there was no difference in the scores between twins. And the authors of these 2 studies suggested that perhaps this excess risk of neurodevelopmental or cognitive difference is unrelated to the general anesthesia or surgery. 3 other studies looked specifically at neurocognitive test scores in school-age children or teenagers. 2 found that there were lower scores in certain domains. However, 1 found no difference in cognitive outcomes between 1, 0, or greater than 1 anesthetic exposure. Many studies have looked at academic performance with many, many patients. 3 found no difference in national test scores between unexposed and exposed kids, and 2 found slightly lower national test scores. 1 showed a much higher rate of formal diagnosis of learning disability. However, this was based on phone interviews with families. As far as learning disabilities and ADHD, there's a retrospective cohort in Minnesota that had been anesthetized between 1976 and 1982, as patients were then assessed for learning disability or ADHD. The authors of the study found that multiple anesthetics, but not a single anesthetic, increases the rate of learning disabilities or ADHD. Followed up several years later in 2017 using a quote-unquote modern anesthetic technique, these authors again found that multiple exposures, but not a single exposure, increased the rate of learning disability, ADHD, and academic impairment. As far as autism, which is a lot brought up by our patients and their families, is that in 2015 there was a matched cohort study looking at greater than 5,000 of exposed children. There was no increase in the diagnosis of autistic disorder in the exposed groups and no association between number of exposures or the development of autism. As far as duration, there were 2 studies that looked specifically at this. 1 was looking at 70 patients who underwent cranial vault surgery. The authors found an inverse relationship between length of exposure to cognitive scores at 36 months, but found that an additional anesthetic did not have any effect. Another study by Ng looked at almost 150 patients who had been exposed to anesthesia before age 3. They found that those exposed for less than 35 minutes had no difference from an unexposed cohort, but greater than 35 minutes, those patients had lower language scores. In conclusion, though the data is mixed, the most robust studies suggest that a single anesthetic agent does not have significant effects on general neural development, academic performance, or the development of ADHD or autism. And general anesthesia does not need to be avoided in childhood. However, practitioners should try to avoid prolonged or multiple anesthetic exposures. For question 2, there were 7 studies. In terms of the timing of anesthesia, an observational cohort study looked at patients operated on for isolated cleft lip, and they found that there was no difference in IQ between those patients operated on at less than 8 days old or between 3 and 10 months old. However, those operated on earlier had improved psychosocial development. A similar retrospective cohort looked at patients operated on for either cleft lip and palate, or cleft palate. An older age at repair had a lower academic performance, suggesting that potentially oral cleft type, not timing of anesthetic exposure, leads to different academic outcomes. Ng et al. Looked at patients who were exposed to anesthesia between ages 3 and 5 or 5 to 10 years old, and found that there was an overall lower motor function in all exposed patients, but there was no difference in language or cognition between any of the groups, and there was no difference in outcomes whether you were operated on earlier or later. Kaufman et al. Sent a questionnaire to parents about behavioral development of their children who had been operated on either before 2 years or between 2 years and 6 years. And in this questionnaire, they found an increased risk of clinically deviant behavior in those patients exposed at a younger age. Finally, 3 other studies looked at different time points of general anesthetic exposure. The first one looking at almost 40,000 patients who were operated on at 11 different time points. These authors found that there was a minimal increased risk of developmental delay, ADHD, and mental illness in all ages, and there was no difference between the age groups. Another study looked at less than 2 or greater than 2 and found that there was an overall difference, small difference in those patients who exposed compared to an unexposed cohort. However, that was only in patients who were operated on at greater than 2 years old at the time of surgery. And finally, another study looked at patients operated on between less than 2 or 2 to 4 and found that there was no increased risk in those patients operated on at less than 2 years old, but a slight increased risk of developmental delay in those patients operated on between 2 and 4. In conclusion to question 2, data suggests that anesthesia may affect different domains of development at certain ages, but there is no conclusive data to support waiting until later in childhood to perform procedures under general anesthesia.
Okay, so I'm Roshni. So we're going to talk a little bit about the last two questions. So the first one is, does exposure to specific anesthetic agents carry more risk than others with regards to neurodevelopment? And are there specific agents that actually might mitigate risks? So there are 4 studies that really looked at this, and they all deal with certain specific agents that we're all pretty familiar with: ketamine, Sevo, nitrous, and TIVA. So let's talk specifically a little bit about the first agents. So ketamine is a very common anesthetic. It was first synthesized in 1962 for anesthetic purposes. We see it used very commonly in the operating room and in the emergency room. It has a very short duration of action. The thing to remember about it is that it is an NMDA receptor antagonist. So NMDA receptor activation is critical for the induction and the maintenance of pain perception. There is some controversial data as to whether ketamine is actually neuroprotective or neurodegenerative. There is animal data that exists that shows that a single dose of ketamine may be neuroprotective. And this is thought to be because it's able to decrease calcium entry into the neurons, which is mediated by NMDA, and prevent apoptosis. So one study looked at this. Buddha, in 2012, developed a prospective, randomized, placebo-controlled study for patients that were undergoing VSD repair. The ketamine dose in this study was 2 milligrams per kilogram. What they looked at is inflammatory markers at 6, 24, 48 hours post-surgery. They looked at MRI imaging, and they did the Bayley Infant Developmental Scale, both pre- and post-surgery. So 24 patients, and they found pretty much that no difference in the expression of cytokines, NSE or S100. NSE and S100 are serum markers of neuronal damage. The only finding that they found that potentially ketamine was protective in terms of an anti-inflammatory response was that the peak concentration of CRP was lower in patients that had been exposed to ketamine. There were absolutely no differences in the Bayley scale or any other evidence of neuroprotection in this pilot study. So then there's some data that says, well, maybe ketamine is actually damage-inducing. There's, again, some primate data that repetitive exposure to of ketamine in primates may induce neuronal apoptosis. And we know that NMDA receptors in the developing brain are expressed, and they're important in neuronal proliferation, migration, and maturation. And therefore, antagonists like ketamine may actually adversely affect brain development in infants and children. So one study really looked at this. This was a 2014 study that looked at repetitive exposures to patients with ketamine. These patients were having short procedures, usually 5 to 7 minutes of age, and they looked at the Bayley scales of infant development and, again, those neuronal serum markers. This was a prospective study. They enrolled patients that were 3 to 22 months of age. The ketamine dose here was much higher than the previous study, so it was 8 milligrams per kilogram, but the procedures were quite short. The interval between each procedure were between 3 and 4 weeks. And so they enrolled 52 patients. 20 of them had 1 ketamine exposure, 16 had 2, and 13 had 3 ketamine exposures. So they looked at their pre and post groups, and they found there was no difference between the groups prior to any ketamine exposures. However, they noticed that there was a significant increase in the S100 levels. Remember, that's that marker of neuronal damage after any exposure to ketamine as compared to the pre-ketamine levels. And interestingly, they found that after the 3rd exposure, there were significant differences between the pre and post exposure testing in the Bayley scale for infant development. So a significant finding here. So we're going to talk a little quickly about Sevoflurane. Sevoflurane we all use in our operating rooms. It's an inhaled anesthetic. It has a rapid onset of action. It's hepatically metabolized. And then there's TIVA. TIVA is we use in our operating rooms often for patients who have some sort of contraindication for inhaled anesthetics. It basically is a co-administration of an IV hypnotic and an opioid. Usually it's often propofol or remifentanil. Their uses are often, it's useful in preventing laryngospasm, and patients may have some decreased nausea or vomiting in the postoperative period. So one study kind of looked at, what is the difference between using Sevo and TIVA? This was a study that looked at patients who were having tonsillectomies. It was a randomized block-controlled parallel group study done at a tertiary care center. 64 kids were randomly assigned to either getting Sevo or TIVA. The outcome of interest was something called negative postoperative behavioral changes. And this is really common in many children who have anesthetics. They include anxiety, sleeping disorders, fears, and enuresis. And there's been several studies that have showed that the persistence of these negative behaviors can actually lead to long-term emotional and cognitive developmental issues. So this study basically did a validated post-hospitalization behavior questionnaire. This questionnaire was filled out by parents at post-op day 1, 3, 7, 15, and then actually 6 months even after surgery. Interestingly, they found that the proportion of negative behavior effects was significantly higher amongst patients who received inhaled anesthetic with the Sevo than those compared to those who are getting the TIVA. The other concerning factor is that the prevalence of these negative behavior factors was still high at 6 months of age. So they concluded that inhaled anesthetics saw more frequent, more prolonged negative behavior responses, particularly in the general anxiety, separation anxiety, and withdrawal and apathy categories. So our conclusion for our question 3 is that in patients that require general anesthesia, consideration of certain drugs, the use of certain drugs such as Sevo and ketamine really should be mitigated, and we should think about a little bit more widespread use of TIVA. This is a level B recommendation. So our last question is, what are the alternatives to general anesthesia, spinal, regional? And what is the data for their safety? So there's 6 studies that looked at this question specifically. Now, obviously, we have all used regional anesthesia. However, for certain techniques, the widespread use has been a little bit limited just because of experience. We see use of spinal anesthetics. It's commonly used in abdominal procedures, hernias, can be used for laparoscopy. Cottles don't provide any motor blockade, and they're good for procedures below the umbilicus, and they're easier to perform than a spinal. So Salim Islam, one of our members, compared the use of spinal anesthesia for laparoscopy and laparoscopic pyloromyotomy. It's a small study, 12 patients in each group, but they really noticed that there were no differences in the duration of surgery, the length of stay, complication, or the time to full feeds. There were, however, significantly and interestingly, a decrease in costs. So less time in the operating room actually allowed them to save over $1,200 per study. The GAS trial that Julia talked about really looked at 363 patients who were randomized to regional anesthetics. In those patients, compared to those who got general anesthesia, there was a decreased incidence of hypotension and a decreased incidence of early apnea. So some significant hemodynamic parameters that are beneficial in patients receiving regional anesthetics. A secondary analysis that looked at failures of those patients who were randomized to regional anesthesia but ended up getting general anesthesia, and they noted that a bloody tap on initial aspiration was the initial factor that was sort of a predictive of not being able to continue on with regional anesthesia. Talk quickly about DEX. Dexmedetomidine is a drug that we see very commonly used in the ICU. It's an alpha-2 adrenergic agonist and has minimal respiratory depression. Very interesting thing about DEX is that unlike many of the other anesthetic agents that we've talked about, it has no evidence in any animal model of any evidence of neurotoxicity. And there's actually some evidence that it may have a neuroprotective effect by attenuating the neuroapoptosis caused by other anesthetic agents. So there's one study that randomized patients who are undergoing inguinal hernia repair to DEX anacotyl and Sevo anacotyl. They randomized 51 patients to DEX and 48 patients to the general anesthetic arm. And they were able to find that with DEX-only anesthetic, that 46 out of 51 patients were able to undergo an inguinal hernia repair. And they found that there was significantly improved hemodynamic stability with DEX during the operation. So they found that there was no significant difference in the overall duration of anesthetic time, the total time spent in the operating room. There were no differences in perioperative adverse events or length of stay. And this use of DEX really negated the need for endotracheal intubation and any exposure to any general anesthetic agent. So our conclusion for question 4 is that regional anesthesia can be performed safely for selected cases and patients, and as new people are bringing in different types of blocks, those are things that we need to study further. The consideration of using regional anesthetic techniques with the addition of DEX may mitigate the risks of neurotoxicity and should be really considered as first-line therapy in selected short procedures. So that's a level B recommendation. So just going back to the beginning and summarizing sort of our questions for this systematic review. Our first question was, does general anesthesia exposure in children pose a risk to their neurodevelopment? Though the data is mixed, and Julie did a wonderful job in going over that, we have to remember that the most robust studies suggest that a single anesthetic dose does not have any significant effects on neurodevelopment, autism, ADHD. So those are the answers you can give your families when they ask you. Our second question, is there a critical window? Should I have this done early? Should I have this done later? Data suggests that anesthesia may affect different domains of development at certain ages, but there's absolutely no conclusive data in the studies that we have now that waiting till someone is 3 years old or 4 years old to perform procedures that require general anesthesia. There's no evidence for that. And our third question, looking at the exposure to specific anesthetic agents, mitigating the risks, potentially using less ketamine, less Sevo. We should think about that, and using TIVA more often. And our fourth question is, can we use regional anesthetics? Yes, they can be performed safely and for selected cases, and we should think about using DEX as well. We are happy to answer questions at the end of the next session.